Yeah. Good morning, judges. So I'll be presenting my paper on cerebral visual impairment, our perspective. CVI has become the leading cause of bilateral visual impairment in the Western world. And in India, its prevalence has increased in children less than 3 years of age, and it has exceeded the cause of congenital cataract and ROP and has become a significant public health problem. Any damage to the visual processing area causes cortical visual impairment. It comprises of visual malfunction due to retrochiasmal visual and visual association pathway pathology. It can be seen isolated or it can accompany anterior visual pathway dysfunction. So the aim of our study was to understand the causes, the radiological features, the prognosticating factors, and impact of timely visual rehabilitation. So it was a prospective study done between Jan 2012 to December 2022. Patients included were children who did not, in whom the ophthalmological findings did not explain the visual performance. There was history suggestive of a stormy perinatal period and associated neurological pathology. So all children underwent a thorough evaluation, including a detailed history, age-appropriate vision assessment, keeping the cognitive ability of the child in mind. MEM retinoscopy was done to look for the accommodation insufficiency. Intraocular pressure assessment was done. Squint and ocular motility assessment was done. They underwent cycloplegic refraction. Anterior and posterior segment was evaluated. Pediatric neurology opinion was taken and underwent neuroimaging. And finally, all the patients were parents were counseled regarding the child's condition. So all children were advised to review after 3 days with the required optical correction for functional vision assessment and planning of the vision training strategies. Children who had ocular visual impairment were treated with adequate measures wherever indicated. We had 199 children, of which majority were boys. The commonest mode of delivery was normal, and we had 87% who were term delivered. The age range was 1.5 months to 216 months, with a mean age of 34.5 months. Almost 70% were less than 3 years of age and 40% were less than 1 year of age, and majority of the children were referred to us by the pediatrician and the pediatric neurologist. The functional vision impairment was classified into 7 levels, with 0 being no perception of light and level 1 to 6 based upon the Hoyts et al. Classification. 1 is perception of light ranging to 6, which is normal visual acuity. Accommodation insufficiency was seen in 5% children. The commonest refractive error in our cohort was compound hyperopic astigmatism, which was seen in 35% children. Exotropia was seen in almost 62% patients, 20% had nystagmus, and more than 50% had optic disc pallor. CVI with ocular visual impairment was seen in 76% children. Of this, 79% children underwent vision training. The commonest cause in our cohort was perinatal brain injury, followed by hypoglycemic brain injury. And the commonest neurological abnormality was global developmental delay, followed by seizures, cerebral palsy, microcephaly. And the associated anomaly, the commonest was congenital heart disease. On neuroimaging, the commonest feature seen was hypoxic ischemic encephalopathy and periventricular leukomalacia, followed by parieto-occipital gliosis. So after visual training, we noticed that almost 11.5% children were high functioning, whereas the rest were low functioning. Of 199 children, 79% underwent visual training, 66 came for follow-up, and there was 1 or 2 level improvement seen in almost 35% children. However, 21% failed to review. So we know that occipital lobe is where the major information comes, and from there the higher visual processing takes place en route to the frontal lobe. The occipitotemporal pathway is responsible for the recognition of object, and occipitoparietal pathway is responsible for spatial processing. The spectrum of CVI can range from very low functioning to very high functioning. The most common cause in the series was HI, which is in accordance with the other studies done in India. 70% children were less than 3 years of age, and this first 3 years are very crucial for the child's overall development. Majority of children were referred, so we know that there is a role of pediatrician and pediatric neurologists in identifying these children and timely referral to us. 48% had very low vision ranging from no PL to PL, and this highlights the implication this condition can have in declining the overall child's development. The commonest refractive error was compound hyperopic astigmatism. This pallor was seen in more than half of the children, but it was not associated with any other ocular cause. So the likely cause here is retrograde degeneration. 5 children had bilateral visually significant cataract who underwent surgery. HIE was a commonest etiology, and GD was a commonest neurological manifestation. Abnormalities on neuroimaging were seen in 97% children. So we had almost 11.5 high functioning CVI. These children go to regular school and often have normal visual acuity, but they can have issues with learning difficulty, decreased scholastic performance, and trouble in sports and socializing. These children are often missed in the regular OPD because of better visual function, but clues in the birth history and asking leading questions about the scholastic performance could help. 21%, despite being diagnosed, they did not undergo vision training because the parents failed to follow up. Many patients were also lost to follow up as they belong to other states and hail from a different country. So, establishing easily accessible CVI centers across the country could help. So, we believe that a thorough CVI assessment at least once could help initiate a therapy, create awareness to the caregivers, and improve quality of vision and promote better follow up. So, I would like to conclude that an emergent need for a comprehensive eye evaluation in any child who has a stormy perinatal period. It requires a multidisciplinary team. Timely intervention for correcting the treatable ocular causes is a must. Creating awareness in the community is the need, and providing various therapies at economical rate under one roof is very, very important in bridging the gap in this predicament. Thank you. Uh, Ma'am, the whole idea behind presenting this paper was like everybody talks about the causes, but nobody actually talks about how many children actually end up coming to you for subsequent follow ups. So the stress was upon this that we should also highlight how we can encourage these parents, counsel them, and make sure that they come for regular follow ups. As I mentioned, as you must have seen, the study is over a period of 10 years. So in children with CVI, you won't ever see instant improvement in the vision. So you have to follow these children over a period of decades to actually see whether they have improvement. And even one level improvement makes a big difference to the child's life. So the idea is to promote a message that we have to start creating awareness. Don't miss out these children. Some may appear to be normal, but there could be certain clues. So taking a detailed history definitely helps. And if you're seeing any children who has a stormy perinatal period, the first 3 months of life only we should make sure that they undergo a eye evaluation, and preferably with a pediatric ophthalmologist, because they would be able to catch these children early on. And yeah, but some of what I've seen is they are the ones who are actually referring. So yeah, in the pediatric neurology. Yes, absolutely. Thank you so much, ma'am. Thank you.
Disclosures. So we all know that artificial intelligence is a booming topic, and we wanted to see whether we can incorporate this in keratoconus and its progression and other associated factors. So coming to risk factors, we know that there are a number of publications which give us a number of risk factors for keratoconus, and we also have published our own 5-point nomograph, which indicates that age, eye rubbing, atopic eye disease, frequent change of glasses, and other factors play an important role in the progression of keratoconus. So we wanted to come and say that can we do a risk stratification in these patients? Can we find out what is the most significant factor that leads to the progression of keratoconus? So we've already published a paper where we used artificial intelligence and the topographic features to indicate whether few patients are either progressors or non-progressors, depending upon the Kmax of the patient. So we saw that there were between two visits, which are 6 months apart, if there was an increase in one diopter of Kmax, that we call them as progressors. So our artificial intelligence model could easily detect this. So next we wanted to see if we can amalgamate this with other high risk factors and demographic factors. So we wanted to create an artificial intelligence model where we were able to process multiple data, and we could easily come and give future outcomes of that patient. So this is my materials and methods. After ethics committee approval, we recruited 500 eyes, and it was a prospective observational study. All the catatonic patients had 2 visits, which were 6 months apart. The first AI model, as I said, indicated whether the patient was a progressor or a non-progressor on the topographic features. And our second AI model aimed at analyzing these with the demographic factors and risk factors. So we went ahead and asked all of these patients a very vigorous data. This was our questionnaire, and you can see that there are multiple data which were asked to the patient. Also, it included the laboratory investigations like vitamin D levels, B12 levels, and the Ig levels. So this was our model. wherein we took so this was a model wherein it took progress. So you can see that there's a branching pattern, and this took a number of parameters like vitamin D, Ig, and everything, and it gave us a data where we could stratify these risk factors. So we saw that IgE was the highest risk factor, which told us that most of our patients who were progressors had a high level of IgE. The second was systemic allergy, and so on. And our model also predicted that on topographic factors, when there were 74% were predicted as progressors, our second AI model with demographic factors and risk factors also showed that they were progressors. And similarly, in stable patients, 70% of them were indicated as progressors on topographic features. And our second AI model, which included risk factors and demographic factors, also said the same. So coming to the discussion, so we added topographic factors, high risk factors, and the demographic data. And our most important outcome was the risk stratification. So we monitored the serum Ig levels, vitamin D levels, and systemic allergy in all of these patients. So how do we bring this to the clinics? We saw a 14-year-old girl with keratoconus, and because of our AI models, we predicted what could be the highest risk factors in this patient. So we asked for those blood investigations. The blood reports indicated that she had a very high level of serum IgE, and vitamin D levels were low. And there were signs of systemic allergy as well from our demographic data, and she had a history of frequent eye rubbing. So we refer this patient to an immunologist and a physician to alleviate these risk factors. And because of that, we saw that she was stable over the next 6 months. So what we already know is that topographic parameters definitely help us detect the progression of keratoconus. And demographic risk factors are also been given, but there has never been a risk stratification in this field. So we came across with the first AI-based model to determine and integrate these demographic and risk factors for progression, and the importance of risk stratification and profiling of the patients, which helps in indicating the disease progression. Thank you. So we wanted to bring about the risk stratification, ma'am. So we wanted to see what is the most important risk factor that helps in indicating whether this patient can go in for progression or not. Yes. Thank you so much.
Respected chairpersons and my dear colleague, I will be speaking on multimodal strategies for public awareness in diabetic retinopathy. As we know, a successful program to combat diabetic retinopathy in part relies upon the level of awareness about diabetes in the community. It appears that awareness of diabetes and diabetic retinopathy is relatively low in many parts of India, making it difficult to engage in preventive actions, diagnosis, or treatment. In a study done in southern India, it was found that awareness that diabetes can cause diabetic retinopathy was present in only 28.8% of the urban population. The aim of our study was to find out the best possible method for increasing the level of awareness in the community about diabetic retinopathy, screening and treatment. In this study, all the screening and treatment programs, camps organized between November 2009 to December 2012 were included. All the camps were organized in the Bagpat district of the Uttar Pradesh. On the day of surgery, a team comprising retina specialists, optometrists, and other team members will go to the venue in a mobile van equipped with portable angiography and laser machine. All the patients requiring angiography and laser were done there itself. As we know, there are three main approaches for any public education program. When a large section of the community is approached, it is known as the mass approach. When a specific group is targeted, it is known as the group approach. And when a specific individual approach, it is known as the individual approach. In mass approach, we have poster depicting the effects of diabetes on the various organs and their prevention. And the posters for the awareness of diabetic retinopathy, they are intended to raise general awareness, and they are contain illustrations depicting the effect of diabetes and retinopathy on the retina. In the similar way, we can make some calendars which can be put on the various places. A small pocket calendars providing regular encouragement for diabetic retinopathy were also made. The main purpose of organizing press meetings is to disseminate knowledge about the retinopathy with various articles in the newspapers. Awareness can also be
यदि आपको शुगर है तो आपको अपनी आंखों की जांच हर 6 महीने में
by these awareness campaigns by celebrities can also be done, and by awareness campaigns in the FM radio.
यदि आपको शुगर है तो आपको अपनी
Coming to the group approach, various seminars and lectures can be organized. This main purpose of seminar is to engage the physicians and ophthalmologists, so can the and also the local health workers and medical personnel. In these booklets were distributed, which contains the basic information about the effect of diabetic retinopathy with various stages, and the ideal follow-up schedule was included in that. By celebrating special World Diabetes days like World Diabetes Day in schools and etc., a large section of the community was approached, which in turn provided the large section of the community was approached. Patient intersections were held at the campsite, followed by a short presentation and a question and answer sections. We can also make pamphlets which contains in the vernacular language containing the basic information and stressing the importance of early detection and brief information about the diagnosis and treatment of diabetic retinopathy. Individual counseling sessions were also held, which provide a perfect opportunity for one-to-one interaction. In our experience, we found that all these approaches are useful in urban and semi-urban areas, but for less useful in rural areas, because people vary so widely in their socio-economic conditions, tradition, attitudes, and beliefs that a mixture of different approaches are required. As we've seen in the camp, that when we give some pamphlets to the patient go outside and he throws the pamphlet. Most of the patients who come these camps, their motive is to get a free eye drop. So we developed an educational movie to impart knowledge about retinopathy, covering all the aspects of diabetes and retinopathy, in which a protagonist who is a diabetic and is based in rural area is repeated counsel as is irregular in treatment and follow.
भी नहीं दिखाई दे रहा है, ठीक है। अभी आप बाद में देखिएगा, उस जगह पे ध्यान से देखते रहिएगा, उस जगह पे सफेदी सी आएगी, दिख रहा है आपको? हाँ जी, हाँ जी, हाँ जी। ये बेसिकली लीकेज है, इसी को हम टेस्ट इसलिए देखने के लिए करते हैं कि
on the first follow-up, angiographic and laser procedure was shown so as to allay the patient's picture.
धर्मू आके मुझे अस्पताल लेके गया दिल्ली इलाज के लिए.
Importance of the follow-up was also emphasized. A sensitive topic was leaders.
कहाँ फिर रहा है? राम राम बाबा, राम राम. खुश रहो, आनंद करते रहो. और बाबा कहाँ फिर रहा है भाई? कहाँ गया था? बाबा दिल्ली से आ रहा हूँ. काहे के लिए? बस आंखों को दिखाने गया था बाबा. अरे आप वही.
The movie ends in the positive note. The protagonist learns from his mistake and in turn takes upon himself to educate the fellow villagers. In our study, total 22,540 patients were examined. Initially, there were 45. After these 45 camps, they were done with the conventional approach, and the next 95 camps in the movie approach was used. So our results showed that a new approach of movie showed approximately significant increase in diabetic patients and 17% increase in patients opting for the laser treatment. Diabetic retinopathy is a major cause of blindness with public health implication in India. Prevalence of diabetic retinopathy in South India among patients over 50 years was found to be 1.3% in one study, and who is going to increase exponentially in the coming decades. In conclusion, I will like to say that people vary so widely in their social conditions, tradition, belief, and level of knowledge that uniform communication approach is not viable. A mixture of different approaches must be available depending upon the local circumstances, and we have to constantly evolve new methods of screening and awareness. Thank you for your patience here.
So, according to you, which is the best?
Sir, as I said in my talk, that you cannot say a particular method for a particular area. Depending upon the level of the knowledge and the awareness in the community, we have to devise new methods, and a mixture of approaches needed in the different places.
So what was different that you did in your study?
Sir, we followed the conventional approaches in the first few camps. We could not get the desired results. So we got the idea of making this kind of a documentary drama in that area only. And this is a 45 minutes movie. I've just shown the clips. And this movie was shown in the local area, in the small cable network and in the small theaters. So it was an interesting movie. The patient also got the message from them, and they more receptive for the
local radio for the local population in
yes.
their language.
Yes.
Do we have Dr. R.C. Singh till now? Move ahead.
Good morning, everyone. Myself, Dr. Ghazal Patnaik, and I shall be presenting our work on preferred practice pattern in both Koyanagi-Harada VKH disease and Indian survey. So, what was the need of this survey? VKH is an old age disease since 1900s, but there exists dilemmas at every strata. Like starting from diagnosis, there is dilemma whether it evolved from Segura's criteria, which relied mostly on CSF pleocytosis, but it was invasive. So it went ahead to American Society of Uveitis criteria. They involved fundus fluorescein angiography in the diagnosis. However, over the years, it was failing to distinguish between an acute and a chronic disease. So then comes revised diagnostic criteria, but it also failed to distinguish between inactive and active, but it is currently the most used criteria to diagnose VKH. So the dilemma started from diagnosis to imaging, where the place of fundus fluorescein angiography, OCT, ICG, indocyanine green angiography, as well as recently OCT angiography has been evaluated to play very important role at every stage of the disease. Coming to the management, there is a debate whether to have an initial oral corticosteroid or to have an earlier immunomodulatory therapy, whether to institute the immunomodulatory therapy within 3 months, or we can even start the immunomodulation as the first line for VKH. Coming to complications, we are most aware of that. The ocular complications is mostly cystoid macular edema. However, from the Indian studies, only 2 studies that has evaluated that the most common is choroidal neovascular membrane. So we desire that the patient ends up without any complication, maybe like this, having Dallen-Fuchs nodules, but mostly nowadays the complications are getting higher with subretinal fibrosis, exudative retinal detachment, even CNVM. So there was the need, and we aim to analyze the preferred practice pattern for managing a case of VKH, and we did an online survey from September 2021 to February 2022 amongst the Uveitis Society of India. So what we saw that there is a discrepancy between the VKH category being viewed by different groups, and we divided the groups as per the specialist years. That is, the uveitis specialist having 0 to 10 years of specialization were group A, 15 to 20 were group B, and more than 20 years was group C. And around 17 people did not reveal their information about the practice of years. So we compared the VKH category encountered by them, the most common ocular feature and extraocular feature, which was quite similar in all the groups. However, the images preference to differentiate between VKH and CSR, it varied from FFA, OCT and B scan as per the numbers. But if you see, it is common almost in all the groups, be it acute, recurrent or chronic convalescent stage. Due to constraints of time, I would be skipping the details. But when we come to the management practice, the duration of oral corticosteroids, there is a huge discrepancy between the earlier group and the group with more than 20 years of experience. The more than 20 years of experience, they preferred a 6 months of oral corticosteroid, whereas the younger one preferred 3 to 6 months of oral corticosteroids. Whereas coming to the immunomodulatory therapy, it was quite common, but there is a split amongst the younger individuals. Consideration of biologic is very recent. However, they do consider after 3 to 4 recurrent cases in all the 3 groups. Complication, however, if we see, they notice macular edema earlier in the course, where it shifts to sunset glow fundus and exudative retina when it comes to younger older experiences. COVID and just changes as the recent parameter, we analyzed that also, but there was no change, and there was a consideration that all the groups had a similar view. So to discuss, when we compared all the parameters between those with a less than 20 years and more than 20 years, we saw the form also changes. Probable is only the ocular manifestation, and more than 20 is incomplete. So over the year, the disease also progresses. What is more important here is the complication. As we see, the complication rate of the sunset glow, it decreases with the group. And to highlight here whether this could be highlighted to the duration of oral corticosteroids or the immunomodulatory therapy, as they also have a discrepancy. So to conclude, many discrepancy prevails, especially regarding the management protocol. With the growing use of immunomodulatory therapy and the newer biologic agents, it is a requirement not only to standardize the diagnostic criteria, but also to standardize the management pattern, so we can deal this dreaded disease and reduce the complication rate as it affects the middle-aged incoming people. Thank you. So I do like no financial interest. Obviously,
it's mandatory that your second slide should be that.
Okay.
And just a piece of advice: don't mention your institute in your slide. Okay. It's supposed to be masked. However, seeing your co-author, we know where you're from.
Yes, ma'am. As I have discussed in the slides also, that younger populations, the discrepancy between the younger and the one with more experience is mainly the management. The younger prefers 3 months of oral corticosteroids and 1 to 2 years of immunomodulatory therapy, whereas the more experienced uveitis specialists, they preferred 6 months of initial corticosteroids along with an early institution of immunomodulatory therapy. And when we saw the complication rate encountered by them, the complication encountered by the uveitis specialists with more experience is lesser and less dreadful as compared to the those experienced by the younger. So maybe it, yes, ma'am, that's what the prognosis was encountered, because this is an online questionnaire, so the exact visual acuity cannot be attained. We performed the questionnaire regarding the visual prognosis, so they gave the prognosis.
So good morning, one and all. Good morning, one and all. I have no financial interest, no conflict of interest. So today I'll be talking about SmartScope Kit, which is a portable eye hospital for screening and outreach camps. I'm Dr. Hirika Gosalia, a postgraduate resident from a tertiary eye care center, catering to a large population, giving high quality service at an affordable rate. By which we conduct outreach camps. We go to outreach camps wherein we are not able to use the conventional instruments, which is quite bulky and can lead to damage during the travel. So in the outreach camps that we go, we mainly screen cataract patients. So here you can see how I'm going to the outreach camp, and we go to a patients with old patients with cataract, and we screen their anterior segment with the torchlight and the posterior segment with the direct ophthalmoscope, and then we refer them to the base hospital. So the problem here was that this was not sufficient to screen many other pathologies, and that's when we came up with the SmartScope kit, which is a comprehensive ophthalmic kit which can do all the necessity investigations. So for visual acuity, we use the smartphone-based free download, which is the eye handbook, by which we can do visual acuity tests, Amsler's grid, color vision. We use the pinhole, we put the pinhole, occluder, and the trial frame. We can also carry along the trial set. Then for anterior investigations of the systemic illness, mainly, we use the BP machine, the SpO2, the torch for examination. Then we use many of the investigations required for the corneal pathologies and the orbital with syringing. And for the anterior segment, we use many innovative devices. We use the iverter, which we use for eversion of the lids, especially for foreign body removal. We use the ASPE, which is the anterior segment photography with intraocular lens, wherein we used which was a great alternative to the slit lamp to examine anterior segment pathologies. So we take a cardboard, we punch the hole, and then we place a 15 diopter intraocular lens at the hole, which is very good for magnifying and giving great resolution to image anterior segment images, which we put on the smartphone. And these were findings that we found at the outreach camps, ranging from corneal findings to cataract findings to neovascular glaucoma to pterygium, and you can see how the resolution and the magnification is. Then we use Shiot's tonometry for measuring the intraocular pressure. We later use we screen the patients for narrow angles, and then we use the ASPE gonio with 8 diopter lens to check the angle of the anterior chamber. Then we heap 4 intraocular lenses of 30 diopters upon each other, which created the IOL scope, which was an alternative to the compound microscope, to screen patients with ulcers to detect fungal hyphae, and we also diagnosed a screened sheep botfly larvae with a patient with foreign body sensation. And we use the Scooby-Doo, which is a smartphone aided cobalt blue filter alternative, wherein we attach the blue filter and the 15 diopter lens to screen many of the corneal findings with dry eye, epithelial edema, epithelial defect, filamentary keratitis, and many other corneal pathologies. And these are all the anterior segment devices that we used. Posterior segment, we used the trash to treasure red cam, wherein we used a sanitizer bottle, and at the edge we cut a round circle wherein we attached a 20 diopter lens. Then on the other side we attached the adapter along with the phone, and this on the other side, then we put it on the patient's eye of pathology to record many of the posterior segment findings. So the results were, we found 83% of cataract patient, and next was retina patients, mainly diabetic retinopathy patients, then corneal findings, glaucoma findings. Others were orbit and neuroophthalmic findings. So in cataract, we mostly found the immature cataracts ranging around 720 patients, mature cataracts. So mainly this was between 4,721 patients conducted across camps across Tamil Nadu, Karnataka, and Kerala. And in orbit, chalazion was most found. In neuroophthalmic, most found was optic neuropathy. In retina, diabetic retinopathy, macular hole was found. So out of the 4,741 patients across 26 camps, we found around around 800 patients were referred to the main center, and there is some issue. 800 patients were referred to the base camp, out of which 200 were received treatment in the cataract section. And out of the patients in the non-cataract, which were the corneal and orbit findings, we referred patients of around 195, and around 85 were treated at the base hospital. So all I'm trying to say is that SmartScope kit is a great alternative to the existing system, and we can screen many segments from the anterior to the posterior segments. 1 second, just give me 2 minutes. Here. Yeah. So coming to results, so out of 4,471 patients, cataract patients were 1,220 patients, and out of which around 700 were referred to the base center for cataract surgery, and out of that non-cataract patient 195 were asked to go to the base hospital, and around 95 were received treatment. So SmartScope kit was a great alternative, ASPE being an alternative to the slit lamp, IOL scope being an alternative to the compound microscope, Scooby-Doo being the alternative to the cobalt blue filter, and the trash to leisure red cam being an alternative to the fundus photography, which is the normal indirect ophthalmoscope. So I would like to ask everybody to use the SmartScope kit to screen, to not miss any diagnosis and to avoid misdiagnosis. Thank you. No, we as residents have tried to use it. Whoever goes, we try to capture images and we discuss if we need referrals, if we are in doubt. So it's a new initiative. We use innovative tools. It's not been used earlier, but right now, since the study we have started, we are using it for all camps. Yes. Only one, ma'am. We were just attaching. Yes, yeah, ma'am. Yes. Not Fevicol, ma'am. It's just a tape, ma'am. It's. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. No, ma'am. So accordingly, we are not using all the devices for all patients. We'll use it according to the patient's complaints. So if the patient is coming with a poor visual, yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. It was adding up to around 7 to 10 minutes more.
Very innovative products. I think next time you should present it in the innovation section.
Yes, ma'am. Yes, ma'am. Thank you.
Dr. Ruhail, I think you are aware that your membership has been ratified and you will be marked. However, please present.
One second.
Today I'll be talking about SmartScope Kit, which is a portable eye hospital for screening and outreach camps. I'm Dr. Hirika Gosalia, a postgraduate resident from a tertiary eye care center, catering to a large population, giving high quality service at an affordable rate. By which we conduct outreach camps. We go to outreach camps wherein we are not able to use the conventional instruments, which is quite bulky and can lead to damage during the travel. So in the outreach camps that we go, we mainly screen cataract patients. So here you can see how I'm going to the outreach camp, and we go to most patients with old patients with cataract, and we screen their anterior segment with the torchlight and the posterior segment with the direct ophthalmoscope, and then we refer them to the base hospital. So the problem here was that this was not sufficient to screen many other pathologies, and that's when we came up with a SmartScope kit, which is a comprehensive ophthalmic kit which can do all the necessity investigations. So for visual acuity, we use the smartphone-based free download, which is the eye handbook, by which we can do visual acuity tests, Amsler's grid, color vision. We use the pinhole, we put the pinhole, occluder, and the trial frame. We can also carry along the trial set. Then for anterior investigations of the systemic illness, mainly, we use the BP machine, the SpO2, the torch for examination. Then we use many of the investigations required for the corneal pathologies and the orbital with syringing. And for the anterior segment, we use many innovative devices. We use the iverter, which we use for eversion of the lids, especially for foreign body removal. We use the ASPE, which is the anterior segment photography with intraocular lens, wherein we used which was a great alternative to the slit lamp to examine anterior segment pathologies. So we take a cardboard, we punch the hole, and then we place a 15 diopter intraocular lens at the hole, which is very good for magnifying and giving great resolution to image anterior segment images, which we put on the smartphone. And these were findings that we found at the outreach camps, ranging from corneal findings to cataract findings to neovascular glaucoma to pterygium. And you can see how the resolution and the magnification is. Then we use Shiot's tonometry for measuring the intraocular pressure. We later use we screen the patients for narrow angles, and then we use the ASPE gonio with 8 diopter lens to check the angle of the anterior chamber. Then we heap 4 intraocular lenses of 30 diopters upon each other, which created the IOL scope, which was an alternative to the compound microscope, to screen patients with ulcers to detect fungal hyphae, and we also diagnosed a screened sheep botfly larvae with a patient with foreign body sensation. And we used the Scooby-Doo, which is a smartphone aided cobalt blue filter alternative, wherein we attached a blue filter and the 15 diopter lens to screen many of the corneal findings with dry eye, epithelial edema, epithelial defect, filamentary keratitis, and many other corneal pathologies. And these were all the anterior segment devices that we used. Posterior segment, we used the trash to treasure red cam, wherein we used a sanitizer bottle, and at the edge we cut a round circle wherein we attached a 20 diopter lens. Then on the other side we attached the adapter along with the phone, and this on the other side then we put it on the patient's eye of pathology to record many of the posterior segment findings. So the results were we found 83% of cataract patient, and next was retina patients, mainly diabetic retinopathy patients, then corneal findings, glaucoma findings. Others were orbit and neurophthal findings. So in cataract, we mostly found the immature cataracts ranging around 720 patients, mature cataracts. So mainly this was between 4,721 patients conducted across camps across Tamil Nadu, Karnataka, and Kerala. And in orbit, chalazion was most found. In neurophthal, most found was optic neuropathy. In retina, diabetic retinopathy, macular hole was found. So out of the 4,741 patients across 26 camps, we found around 800 patients were referred to the main center, and there is some issue. 800 patients were referred to the base camp, out of which 200 were received treatment in the cataract section. And out of the patients in the non-cataract, which were the corneal and orbit findings, we referred patients of around 195, and around 85 were treated at the base hospital. So all I'm trying to say is that SmartScope kit is a great alternative to the existing system, and we can screen many segments from the anterior to the posterior segments. 1 second, just give me 2 minutes. Here. Yeah. So coming to results, so out of 4,471 patients, cataract patients were 1,220 patients, and out of which around 700 were referred to the base center for cataract surgery. And out of that, non-cataract patient 195 were asked to go to the base hospital, and around 95 were received treatment. So SmartScope kit was a great alternative, ASPE being an alternative to the slit lamp, IOL scope being an alternative to the compound microscope, Scooby-Doo being the alternative to the cobalt blue filter, and the trash to treasure red cam being an alternative to the fundus photography, which is the normal indirect ophthalmoscope. So I would like to ask everybody to use the SmartScope kit to screen, to not miss any diagnosis and to avoid misdiagnosis. Thank you. No, we as residents have tried to use it. Whoever goes, we try to capture images, and we discuss if we need referrals, if we are in doubt. So it's a new initiative. We use innovative tools. It's not been used earlier, but right now, since the study we have started, we are using it for all camps. Yes. Only one, ma'am. We were just attaching. Yes, yeah, ma'am. Yes. Not Fevicol, ma'am. It's just a tape, ma'am. It's. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. No, ma'am. So accordingly, we are not using all the devices for all patients. We'll use it according to the patient's complaints. So if the patient is coming with a poor visual, yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. It was adding up to around 7 to 10 minutes more.
Very innovative projects. I think next time you should present it in the innovation section.
Yes, ma'am. Yes, ma'am. Thank you.
Dr. Ruhail, I think you are aware that your membership hasn't been ratified and you won't be marked. However, please present.
One second. Good morning, everyone. I'm Dr. Ruel. I'm a resident, and I'll be talking to you today about the influence of revised RNTCP guidelines on the prevalence of ethambutol optic neuropathy. I have no financial disclosures. As we all know, tuberculosis is a huge burden in India, and in 2019 alone, India reported 2.5 million cases of active tuberculosis in that 1 year. So the RNTCP, to eliminate TB, came up with the NTB strategy, and one of their protocols, one of the changes was to change the protocol of treatment of TB itself, and this came out in 2016. So in this revised guideline, the intensive phase was only, the ethambutol was given not only for the intensive phase, but also for the continuous phase. And from not only three times a week, it was changed to a daily regimen. So we hypothesized that this longer duration of ethambutol given would have a greater chance of developing ethambutol optic neuropathy. And our aim was to document this influence of the revised RNTPC guidelines on the prevalence of ethambutol optic neuropathy in a hospital-based setting. So ours was a multicentric retrospective descriptive study of new patients at the neuro-ophthalmology clinic at a tertiary eye care center in Tamil Nadu in 3 sub-centers, Madurai, Coimbatore and Tirunelveli, between Jan 2017 to August 2022. We included all new cases of ethambutol optic neuropathy that were diagnosed during this period. And those cases where there was a diagnostic dilemma, where the duration of ATT was not clear, were excluded. So we searched the electronic medical records for all cases with the history of taking ATT or were on it during this period in the 3 centers. And we got a total of 2,832 cases with a history of taking ATT. The same electronic medical records were searched for new cases of ethambutol optic neuropathy during this time among the 3 centers. And we recorded a total of 212 cases of new ethambutol optic neuropathy, as well as 41, out of which 41 cases came for a follow-up for at least 4 months after stoppage of ethambutol. So we calculate prevalence in each year by the number of new cases diagnosed with ethambutol optic neuropathy divided by the number of cases that had a history of taking ATT or were on it in that year. So we analyze the age, the gender, the comorbidities of the patients, the duration of exposure of ATT, as well as the visual acuity, both presenting and final. And these were our results. The overall prevalence increased from 1.6 to almost 3 times to 5.49% in 2000, from 2018 to 2019, and it further increased in 2020, only to fall back in 2021, which we attribute to the effect of COVID-19. Most of our affected individuals were males, and they were between the age group 31 to 70 years. They were equally divided between this age group. Diabetes and hypertension was the predominant comorbidity in almost half our patients. And ATT exposure was around 6 months. The mean ATT exposure of most of our patients before presenting with ethambutol optic neuropathy was around 6 months, with even 1 month of ethambutol, even after 1 month, and even at the max 23 months presenting as well. And there was an average delay between time to diagnosis over 2 months. So patients were sitting at home with these symptoms for around 2 months. As you can see in this graph, only 8% of patients presented with ethambutol optic neuropathy within the 2 months, of which was the traditional protocol. Around the rest, 92% of cases presented in the extended spectrum of ethambutol being given. Visual acuity of most of our patients was 6/60, and the final vision was only 6/30 in those that came for follow-up. When we compared initial vision to the follow-up vision, we found that a better initial vision at presentation was predictive of better visual acuity, and those who presented with lower visions like 1/60 had a worse follow-up visual acuity. In this Kaplan-Meier survival curve, we compared time after ATT and the chance that they would improve after stopping ethambutol. And we found that after 6 months of ATT, there was a very low probability of visual improvement after stoppage of ethambutol. And those patients who were exposed to at least 6 months had a very low prognosis of improvement. I'd like to conclude by saying there was an increase in prevalence of ethambutol optic neuropathy, and duration of AT is highly associated, but this might not be the only factor. There's an avoidable delay to diagnosis of around 2 months, and this plays the role of awareness among patients. Ethambutol optic neuropathy may not be completely reversible, as can be seen by the final vision outcomes, and improvement of vision may depend on the presenting vision. Our limitations was, it was a hospital-based study and cannot be applied to the community. And secondly, COVID-19 really affected our data collection. As a take-home point, there must be an increased awareness among all healthcare providers who are treating tuberculosis, and every patient must be educated on the possible side effects of ethambutol to avoid delay in diagnosis. These are my references, and I'd like to thank my mentors, Dr. Siddharth and Dr. Padmavati.
Good morning, everyone. Can I have my slides, please? Yeah, I will be talking to you, all of you, on novel method to screen patients for glaucoma by translead tonometry. This is basically a community-based project. This was developed in collaboration with the Vishweshwaraya National Institute of Technology, so I acknowledge all the engineers there. As you know, approximately 11.2 million persons aged 40 years and above have glaucoma in India. Many people go blind undetected. Therefore, there is a necessity to screen patients for glaucoma at large. In the light of existing manpower and resource constraints, we evaluate options for screening glaucoma. The only modifiable risk factor for glaucoma is intraocular pressure. There are various methods which are available for the measurement of the IOP, and the applanation tonometry by handheld or by slit lamp mounted is the basic one and the most appropriate one and gold standard. So the drawback of the applanation tonometry is you need to indent the cornea, the cost which is involved, and the physician need for the measurement of the intraocular pressure. So we have developed this device without compromising on the quality. The working principle of this method is the Imbert-Frick principle. When you apply pressure on the sphere, the volume inside the sphere is equivalent to the pressure which is applied and the surface area. The same principle being used. This was the experimental device which was developed. It has a cylinder with plunger and a pressure sensor. The plunger has a circular plate of approximately 3.06 mm. The tip of the plunger was placed over the closed lid. This is the experiment which we perform. It has a cylinder and you can see it is pressed over the closed lid, and the cylinder has a sensor which was carrying the signal to the indicator either in the form of red or green. It was adjusted to 20 mm of Hg. If the pressure was more than 20 mm, it was red, and if it is less than 20, it was green. So the initial device which was developed was cumbersome and with lot of wires, but it was detecting the intraocular pressure either less than 20 or more than 20. So there was lack of digital reading. So we developed the finite element model, and the 3D analysis of the same thing was done. So, but there was a problem of lid pressure. When we indent the lid, there is always a problem of lid indentation. So that was also taken into consideration. When we indent the lid, the pressure which is exerted by the lid is around 4.1 mm, which was adjusted to the sensor. So the device was modified to this one, which was giving the digital reading also, and the changed sensor, which was high sensitive pressure transducer, was introduced. The testing of the device was done at the tertiary eye care center with ethical approval from the hospital. A single observer which was proficient in taking intraocular pressure by applanation was considered, and he measured with applanation method as well as with the new device. The initial reading was with the new device after interval of 15 millimeter. After interval of 15 minutes, IOP with applanation was taken, and three readings were taken, and the mean of 3 reading was considered. Assignment was consecutive, and the patients coming to the OPD. Exclusion criteria were patients with corneal opacity, operated case of glaucoma, lid abnormalities. Those who underwent refractive surgeries were excluded. Data was compiled and filled into the Excel sheet. So this was the area which was needed to be indented. When we close the lid, there is elevation which is there, and this area need to be indented. And this was with the device. The device had a plunger which was of 3 mm size, and the area of the plunger was 3.06 mm. So it was giving the digital reading also. The cleaning of the device you can do with the sodium hypochlorite or with the saline also. The statistical methods which were applied were Mann-Whitney test, regression analysis between two groups, Pearson's correlation, and the sensitivity and the specificity of the device was also done. The total eyes which were screened were 956. This shows the mean age, number of males and females, and with applanation method, it was 14.18 mm. The range was 7 to 48 mm, and with the new device, it was 10 to 15. Range was 10 to 15.8 mm of mercury. So there was not much of difference. This was the coefficient of correlation between the two devices. It was almost correlating, and the sensitivity of the device was 90%, shows that it is able to detect positive glaucoma subject 90% accurately, and the specificity of the device was 88%. The advantage of the device is portable, simple for health workers in rural areas, a simple method to measure IOP, no need of ophthalmologist. If patient wants to measure IOP at home, but he need to teach about the things, the screening of the patient in camps and rural areas, and no need of local anesthesia and fluorescence. The limitation of the device is we are in process of fitting camera on the plunger, so that we will come to know the exact position of where it is indented, and multi-center studies which are required. So the conclusion of my study is that detailed statistical analysis showed no significant difference between the IOP measured by the applanation and the tonometer. And it is an excellent device, zero contact with cornea or influence of corneal biomechanics on IOP results, provides best way for rapid screening of this patient in the community settings. Thank you.
Dr. Rajesh, are you aware that such a device is available commercially in the market?
In fact, there is a transscleral device which is available. We need to place it over the superior aspect of the limbus, and that measures the intraocular
pressure. If you get a chance, visit the Medicine's devices stall. I think they have one which measures over there.
It is a transscleral.
So have you ever tried remote thermometer?
No, sir.
Because remote thermometers are a very simple device. I'm using so many years. It is comparable information that is reading some comparable information. And it's there's no need to guys I even we can use it with child also.
Yes. Yeah. The duration needed is very short, and it will come in market shortly. Yeah, for home care. Yeah. Yeah. Thank you.
So, good morning, respected judges and friends. I'm going to present my paper on digital revolution in glaucoma screening, now offline on a smartphone. These are my financial disclosures. Sir, it's not moving, sir. So, Dr. Venkatesh, me, and Dr. Kavita do not have any financial disclosures. Dr. Divya Rao works for Remedio. She's a medical director over there. So, as we all know, previously undetected glaucoma levels, according to the prevalence studies, show that the vast majority of glaucoma in less developed nations are undetected, and about from 50% of that is advanced disease, and 20% of them are blind. So there is a need to screen there is a need to have a device which screens faster. So using this offline on the edge AI integrated on a smartphone fundus camera, it generates a referral report in 10 seconds. It can be used at any time, any place, whether it is a remote camp where there is no internet or electricity. It can be used in vision centers and also at home, and it can be used by anyone, whether it is a MLOP, optometrist, or general ophthalmologist. And this AI generates a report, and it just does not give vertical CD ratio, but it also highlights areas of concern. As you can see in the picture, it shows it highlights the RNFL defects also. So the purpose of our study was to assess the performance of this novel automated screening tool for referable glaucoma using an offline AI deployed on a smartphone based fundus camera against specialist diagnosis using gold standard slit-lamp biomicroscopy. So this was a prospective cross-sectional study done between June 2022 to December 2022, with the 56% being male, and the mean average population was 53.27 years. And the major first outcome was diagnostic accuracy of this AI against the glaucoma specialist. And we refer by referable glaucoma, we mean both definite glaucoma and dyssuspects. So a sample size of 200 patients was calculated such that the measured rate of discordance in referable glaucoma between the AI and the glaucoma specialist would differ from the true rate of discordance by less than 8%, which is normally 10 to 50%, and the sensitivity should be of at least 80%. An equal distribution of glaucoma, dyssuspects, and no glaucoma was aimed at between these 200 patients. We included all patients above 18 years who were willing to give consent, and we had a glaucoma group, a normal control group, dyssuspect group, and we took fields which were reliable with the false positive and false negative of less than 20%. We excluded all patients who had acute conditions where narrow angles where dilatation was contraindicated, retinal pathologies precluding the view of the disc, or any media opacity cataract grade more than nuclear sclerosis grade 3 was excluded. And also participants who were, in the opinion of the investigator, who would prelude the participation in the study, like uncontrolled intraocular pressure, active infection less than 3 months post glaucoma filtering surgery, and also those in whom the imaging was contraindicated, where the patient was hypersensitive to light or recently underwent photodynamic therapy. So this is a flow chart. We had 3 groups: normal, dyssuspects, and known case of glaucoma. They all underwent vision testing at on-Stellen's chart, and then an undilated fundus photo was taken by the Remedio fundus on phone camera. If the image sufficient, if the quality of the image was sufficient, the AI was run on the image, and the AI interpretation and the VCDR was noted. And if the image quality was not sufficient, 2 attempts were needed, were again given to the optometrist or the MLOP to take a sufficient quality. Again, if it is not coming of sufficient quality, then the patient was dilated after all these preliminary testing like IOP, gonioscopy, visual field testing, and then pupillary dilatation, and then after dilatation, grading of the cataract and dilated fundus photo was taken, followed by OCT. Again, the AI was run for interpretation only on those cases where the undilated image was not good enough. So, and then all the findings were noted. And then finally, these patients were given to a glaucoma specialist who was masked to whether this patient is a part of the study or not. So as we were doing normally, how we see a glaucoma patient or a suspect or a normal, we did that. Wherever required, we did HFA and OCT. So these are the results. According to glaucoma specialists, there were 94 plus 55 referable glaucoma, which includes glaucoma and suspects. And according to AI, it was only true positives were 128. Glaucoma specialists gave 149 as referable glaucoma, and according to AI it was 128. So the sensitivity or the true positivity was 85.9%. For no referable glaucoma, according to the specialist, there was 66, and according to AI, the true negatives were 64. The specificity was 97%. So the sensitivity was 85.9, specificity was 97%, positive predictive value was 98.5, and negative predictive value was 75.3. So sensitivity and specificity was high, and it was like it was comparable to the specialist diagnosis, and AI showed robust performance in detecting referable glaucoma with minimal overcall of normal cases. So to conclude, novel AI integrated on a portable fundus camera can have a significant impact in screening for referable glaucoma. It can be implemented in population-based or vision center-based model by minimally trained personnel. It can be a support tool for ophthalmologists through timely referral, especially in resource-constrained environments, and it has the potential to make glaucoma screening accessible, affordable, and effective. The limitations of our study was AI was evaluated only in Indian population, so generalizability across the populations is to be determined, and performance evaluation based on severity of glaucoma has not been done, so it has to be done in the future. Practical implications: Remedio fundus on phone with offline AI for glaucoma can be used for mass screening at remote places, schools, community halls, and workplaces, and AI can help in reducing unnecessary referrals. Thank you.
Can you please start once again?
Glaucoma using an offline AI deployed on a smartphone based fundus camera against specialist diagnosis using gold standard slit lamp biomicroscopy. So this was a prospective cross-section study done between June 2022 to December 2022, with the 56% being male, and the mean average population was 53.27 years. And the major first outcome was diagnostic accuracy of this AI against the glaucoma specialist. And we refer by referable glaucoma, we mean both definite glaucoma and suspects. So a sample size of 200 patients was calculated such that the measured rate of discordance in referable glaucoma between the AI and the glaucoma specialist would differ from the true rate of discordance by less than 8%, which is normally 10 to 50%, and the sensitivity should be of at least 80%. An equal distribution of glaucoma, suspects, and no glaucoma was aimed at between these 200 patients. We included all patients above 18 years who were willing to give consent, and we had a glaucoma group, a normal control group, suspect group, and we took fields which were reliable with the false positive and false negative of less than 20%. We excluded all patients who had this, acute conditions where narrow angles, where dilatation was contraindicated, retinal pathologies precluding the view of the disc, or any media opacity cataract grade more than nucleus sclerosis grade 3 was excluded. And also participants who were in the opinion of the investigator who would prelude the participation in the study, like uncontrolled intraocular pressure, active infection less than 3 months post glaucoma filtering surgery, and also those in whom the imaging was contraindicated where the patient was hypersensitive to light or recently underwent photodynamic therapy. So this is a flow chart. We had 3 groups: normal, dissuspects, and known case of glaucoma. They all underwent vision testing at on Snellen's chart, and then an undilated fundus photo was taken by the Remedio fundus on phone camera. If the image sufficient, if the quality of the image was sufficient, the AI was run on the image, and the AI interpretation and the VCDR was noted. And if the image quality was not sufficient, 2 attempts were needed, were again given to the optometrist or the MLOP to take a sufficient quality. Again, if it is not coming of sufficient quality, then the patient was dilated after all these preliminary testing like IOP, gonioscopy, visual field testing, and then pupillary dilatation, and then after dilatation, grading of the cataract and dilated fundus photo was taken, followed by OCT. Again, the AI was run for interpretation only on those cases where the undilated image was not good enough. So, and then all the findings were noted, and then finally these patients were given to a glaucoma specialist who was masked to whether this patient is a part of the study or not. So as we were doing normally, how we see a glaucoma patient or a dissuspect or a normal, we did that. Wherever required, we did HFA and OCT. So these are the results. According to glaucoma specialists, there were 94 plus 55 referable glaucoma, which includes glaucoma and dissuspects. And according to AI, it was only true positives were 128. Glaucoma specialists gave 149 as referable glaucoma, and according to AI it was 128. So the sensitivity or the true positivity was 85.9%. For no referable glaucoma, according to the specialist, there was 66, and according to AI, the true negatives were 64. The specificity was 97%. So the sensitivity was 85.9, specificity was 97%, positive predictive value was 98.5, and negative predictive value was 75.3. So sensitivity and specificity was high, and it was like it was comparable to the specialist diagnosis, and AI showed robust performance in detecting referable glaucoma with minimal overcall of normal cases. So to conclude, novel AI integrated on a portable fundus camera can have a significant impact in screening for referable glaucoma. It can be implemented in population-based or vision center-based model by minimally trained personnel. It can be a support tool for ophthalmologists through timely referral, especially in resource-constrained environments, and it has the potential to make glaucoma screening accessible, affordable, and effective. The limitations of our study was AI was evaluated only in Indian population, so generalizability across the populations is to be determined, and performance evaluation based on severity of glaucoma has not been done, so it has to be done in the future. Practical implications: Remedio fundus on phone with offline AI for glaucoma can be used for mass screening at remote places, schools, community halls, and workplaces, and AI can help in reducing unnecessary referrals. Thank you.
Can you please start once again? Dear colleagues, so this is my paper on innovative IOL, which is a rigid IOL, which is focal in nature. So cataract is does not look at anybody as to whether the patient is able to afford or not able to afford for multifocality. Sorry, I'm not able to get this. No, when my slides are just moving on its own. So this is my financial disclosure. So this lens is developed by the entrepreneurs, Dr. Ramesh C. Shah from Borivali, Mumbai, Dr. Jagdeep Kakadia, and Dr. Vikrant Bhale of Lifeline Medical Devices. So this IOL was developed with
intention of having both near, intermediate, and far distance vision for the patient without the use of principles of refraction and diffraction gratings. So there are no rings. That's how we will be able to prevent the incidence of halos and negative and positive dysphotopsias. So every patient is entitled to have a multifocal vision because cataract doesn't see at anybody whether he is able to afford or not. But most of these multifocal IOLs are manufactured in foldable form and with so many disadvantages. So this is how the vision is seen in this polyfocal IOL with no evidence of positive or negative dysphotopsia. So this was developed on a technique called DIN, where we have distance, intermediate, and near by green technology, that's gradient refractive index, just like a progressive glass that we wear externally. This IOL has been developed in a polyfocal zone, where a progressive zone is made from the center towards the periphery. So there's no loss of light energy also. This is a large IOL, about 7 millimeters in size, the optic size. So this being a rigid PMMA, so this will be the first ever lens of a progressive lens, so-called progressive lens, which we call it as an autofocus lens, because we call progressive as a misnomer, where you have got diffractive and refractive gradient causing where the rings are present. So we did a study of a sample size of 40 eyes of 34 patients with 22 males and 12 females. We excluded the patients with corneal opacity, retinal disorders, and optic atrophy. And all the surgeries were performed with a 6.5 mm sclerocorneal tunnel, and the incisions were taken on the steep meridian to set right the astigmatism, pre-existing astigmatism, up to 1.5 diopters also. And these were the results that we got. So it is 612 to 66, and N vision, near vision was N8 and N6. No PC was noted in any of these cases because the large sized IOL, and it used to say have a full touch with the posterior capsule, and the mean follow-up was about 16 months. So this is the results of these IOLs, both the eyes in 18 months post-op follow-up. And this being a large sized optic, it does not interfere in any of the retinal procedures like laser photocoagulation in diabetics, and there is no double or triple diffraction of green laser spot if at all they need PRP in future. And this will be advantageous for people using for the indirect ophthalmoscopy for examination of the retina for treatment and surgery. And this is the IOL that is now going to be commercially promoted. We call it as $1 million optics, and the brand name is Solitaire. So these are the specifications with an optical A constant of 118.71 or 118.53. So the lens has advantages of no positive dysphotopsias, no glare, no halos, no waxy vision, photic phenomena, and we want to make it affordable to all the population, where the expensive foldable multifocal IOLs are the norm in the present day. In most cases, we had vision of 6 by 6 or better, and unaided vision of N6 at 12 to 14 inches. The patient was comfortable with computer vision with excellent from 2 to 4 feet, and women who were working on the kitchen platform had better vision for working, and even the patients who were needing work for, say, threading the needle in low light, even after bilateral surgery, this was advantageous. So the patient has very quick adaptation, even if the patient has been implanted with a monofocal IOL in other eye. So this IOL can be implanted in other eye also. We haven't tried it in a patient with a multifocal IOL in the other eye. So I feel that this is everybody's birthright, because cataract does not know whether the patient can afford or not afford for a multifocal IOL. So this is going to be cost effective for the large population. Thank you for the patient here.
Now that most of the surgeries are converted to phaco emulsification, do you all intend to make a foldable one also on this type?
No, so foldable is already made, and we have already commercialized it. So about 65 doctors who have invested in this company, and the foldable IOLs is made in a co-polymer platform, and also the hydrophobic IOLs are going to come in future. So this is basically for an unaffordable population who are not able to afford the cost of the multifocal IOL at present. This would be costing between 1,500 to 2,000 rupees now.
A very good morning to one and all. So I'll be presenting the topic on effectiveness and future implications of COVID-related risk stratification in managing retinopathy of prematurity, the Indian Twin City report number 10. So these are my affiliations. I have no financial interest. So as we know, the COVID wave hit us like a tsunami wave in 2020, with most of the essential services were closed. But ROP was a very important essential service that needed utmost importance, and it is a time-bound disease. So we could not halt this, and it has to be in progress. So the Indian ROP Society came with a set of guidelines. It included both the safety guidelines as well as the risk stratification guidelines. So we kind of validated these Indian ROP Society guidelines to see how effective this is. So the safety guidelines, as we know, here is the proper hand hygiene or sanitization, or see the quarantine stamp of the parents, and also the face masks and other proper COVID gear. And the risk stratification guidelines, where the Indian ROP Society divided the babies into high risk and low risk. Low risk are the babies which are systemically stable, which have good weight gain, and who are above 34 weeks of postmenstrual age, and who are more than 1,000 grams of birth weight. So in low risk babies, we kind of try to reduce the frequency of follow-up, because we have limited resource during COVID, and give the maximum outcome and make sure none of the babies went into retinal detachment. Whereas the high risk babies, the very low birth weight and other babies, we followed the old guidelines itself. So we strengthened our outreach services. So we can see, out of the 200 babies screened during the first wave of COVID, the majority of 143 babies were from the outreach hospitals in and around Hyderabad, whereas 57 were from the Apex Center. So let us see some of the safety guidelines that we followed. So here we can see the mother will place the baby in the cradle, and we do not want any of the sisters or mothers to overcrowd there. We ask the mother to step behind, and only the doctor screens. The doctor screens the baby under the radiant warmer, connecting all the monitors. And with this, we can reduce the transmission of COVID to mother or the sisters or the doctor, or the transmission to the baby itself. So we do not want too much of crowding to happen. This is in a very stable babies that come to our OPD. So if the babies were much more sick babies, or which babies in NICU, we use these acrylic boxes to screen the babies. So we can see these are acrylic boxes which have hands, these kind of protect the babies from this COVID transmission from the doctor or any other attendant who are nearby. And it has a nice hand holes to where we can easily screen these babies. So by this we can reduce the COVID transmission to the babies, as well as the parents or the sisters, and also the doctors. So these were the safety guidelines that we took into account. So what are the stratification guidelines? So I said these stratification guidelines were followed only low risk babies. So low risk babies with very mild ROP, we kind of reduce the follow-up, or we extend the follow-up by 1 week. That is, if it is zone 2 anterior or zone 3, we kind of reduce the follow-up by 1 week. That is, we postponed the follow-up by 1 week. Whereas if the baby was pre-plus, and if pre-plus babies we treated early, because pre-plus babies, there are high chance of them losing to follow-up if you call them in the next week. So we treated the pre-plus early, because the apprehension of the parents to reach the hospital, or if they miss the follow-up. So anticipating this, we treated the pre-plus early, whereas very mild ROP we follow-up, we reduce by 1 week. And if the babies had AP ROP, which needed immediate anti-VEGF injection, Then we gave the anti-VEGF injection on the same day, and we followed this baby by teleconsult. So we did not want to call the baby after one day to check whether the baby has endophthalmitis or not. This follow-up can be reduced by doing teleconsult, where the parents will, or the NICU neonatologist will send the WhatsApp image or the email with these baby photos. So if at all baby has lid edema or congestion, that will alarm the treating doctor that the baby has endophthalmitis. Then only we call them to the clinic. Same for the even the surgically treated stage 4A or stage 4B ROP also, we kind of reduce the follow-up by teleconsult. So we found out that in our study that with this new validation of the IROP Society risk stratification, that none of the babies with no detachment went for detachment. So this is no way a suboptimal. This is a calculated risk that was taken in low risk babies to reduce the number of frequency and the transmission of COVID. So we found out that none of the babies went for detachment. So the new risk stratification is no way suboptimal. It can be easily, it's a calculated risk that is taken in low risk. And of course, the risk stratification and the COVID safety guidelines, both in terms of increasing the, reducing the frequency of follow-up, is important. So we found out all these, not just the doctors, even the neonatologists, nurses, technicians, drivers, housekeeping and security staff all played a hand in role. We might have forgotten this now, but during the pandemic, it was very important that teamwork and coordination did the work for us. Thank you.
Without wasting time, I invite Professor K.C. Sinha.
Thank you very much to AIOS and the judges for bearing with me. Can I have my paper, please? Do we have a pointer? Pointer? No pointer? Okay. Can you start? No, this is not it. This is Kirti Khoka. Kirti Singh, abhi diya na gaps. Free paper, I think it's 6-3. I just gave it to you. So it's a pleasure to present.
इसके पहले वाला फोल्डर
ये आपने अगला वाला शुरू कर दिया शायद.
इसके ऊपर वाला
This presentation from Guru Nanak Eye Center. Thank you for AIOS for this opportunity. Patient profile and referral practices for glaucoma. What are the goals which are still unmet? How do I forward it? You'll have to start the timer again. Beta forward nahi ho raha isme. Okay. How come there is? If you could just start the timer again, please.
Ma'am, we'll have 30 seconds to continue.
Okay, no problems. So any goal will have good strategies can still fall through the cracks if we don't do a gap analysis. And for this gap analysis in any healthcare system, we need to have studied two players. The two players are the doctor and the patient. And that's exactly what we did with the aim of evaluation of clinical characteristics of cases referred to glaucoma in Guru Nanak Eye Center, New Delhi, a tertiary care medical college, to study both the knowledge and health-seeking behaviors of patients with glaucoma, and most important but not the last but not the least important would be the referral practices of glaucoma cases with special emphasis on missed angle closure glaucoma. It is a hospital-based observational cross-sectional study, and all the patients coming to the glaucoma clinic, all the primary glaucoma cases were taken. The outcomes were the subtypes and type stages of glaucoma. And the second primary outcome was missed ACG diagnosis or documentation by the first care doctor. Secondary outcome was the patient awareness and knowledge of glaucoma by a self-designed validated questionnaire adapted from Prabhu et al. Duration of symptoms and reasons for delay in presentation. Why were these outcomes taken? Because this is what I found over last so many years of doing glaucoma practice that that's a problem. So 500 adult patients with primary glaucoma, 60% males, 86% were 7th decade or older, of mixed ethnicity, both Hindus and Muslims. Majority at 43% lacked any formal education. They were coming to the government sector. 74% had no source of income. They were dependent on their children. That's important because in glaucoma, you don't treat just the eye, you treat the patient. There was no health insurance for any at that stage. 85 patients were residents of Delhi. Despite that, Delhi is a wide sprawling city. 73% traveled 10 to 30 kilometers for drug refills. The delay in treatment, seeking treatment of more than 6 months, was seen in 41%, and 1 to 6 months was in 48%, which was huge. And this delay was due to ignorance in 62%, no access to nearby health facilities, and mind you, this is sitting in Delhi, the capital of India, 36%, and lack of caregiver, the important thing, 22%. This picture shows you exactly what the problem with the caregiver is. Most of these patients are old, and this son-in-law brought the mother-in-law, the son doesn't take care, so I'm going to bring her, and she had come with end-stage glaucoma. The glaucoma subtypes, as expected, POAG was equivalent to PACG, as has been published from our hospital previously. 48% had severe visual defect, legal blindness in 37%. Of all the blind patients, PACG compromised 46%, almost half. 1/4 cases required laser or surgery prior treatment. Now, this is the important thing. 28% had already undergone a prior filtering or a cataract surgery. 62% were on anti-glaucoma medications. On the ACG subtype, only 20% had a prior peripheral iridotomy. 80% were undiagnosed. And most of these PIs were done in our hospital. Referral practices, prior diagnosis of glaucoma was seen only in 20%, despite many of them being on anti-glaucoma medications, despite a qualified ophthalmologist being the referring physician in 92%, and 28%, as I said before, had a prior ocular surgery, invariably cataract. The criteria for referral to our clinic was high IOP in 60%, dissuspect 39%, poor vision, visual field suspect, gonio suspect was abysmally low at only 5.4%. Gonioscopy had been neither performed nor documented in 80% by the primary care ophthalmologist. And that's a really, really sad situation in India. This is the referral practices. As I said, 92% had been seen by a qualified ophthalmologist. None of them had done a gonioscopy, and they had missed angle closure glaucoma, which in time could have been prevented. Patient awareness was poor at 9.2%, knowledge even less. 95% were ignorant about the cause. Only 8% understood irreversible nature. 5% felt IOL would reverse it. 20% were unaware that after surgery also they would need follow-up. This is our the questionnaire which we designed, and this has been echoed. We are echoing the many studies of Venkataraman et al. From Coimbatore and the Chennai study which says gonioscopy was not performed. Determinants of awareness were occupational, educational status, and disease knowledge, and surprisingly negatively associated with older age and male gender. Poor adherence also was analyzed. Irreversible disease and no perceived benefit, difficulty in using medication, asymptomatic disease in early stages, and hand-eye coordination problem and forgetfulness were the main common cause. So goals still unmet are patients presenting with advanced disease in 48%, delay in treatment results from ignorance, poor access to health facilities, lack of caregiver, despite ACG comprising 50% of hospital glaucoma population. Referral practices or lack on performance of essential gonioscopy was pretty bad, 80%. Awareness was poor at 9%. Education and lack of disease were identified as a key things. So our learning was education is required, perspective, surgical option, exercise early. Many patients depend on free medications, do rational therapy. And again, in the gap analysis, we started doing a gonioscopy and perimetry workshop in our hospital, successfully 2 done over the last two years, and our counseling practices. Thanks to my glaucoma team.